Hepatic disorders. Heather A. Sweeney, 992. Acute liver failure, alpha, general information 1. ALF is a rare condition. The United States approximates 2,000 cases a year. It is classified by a rapid deterioration, less than 26 weeks, of liver function, which results in jaundice, coagulopathy, international normalized ratio, INRA, greater than 1.5, and hepatic encephalopathy in previously normal individuals. 3. The most common causes of ALF are drug-induced liver injury, viral hepatitis, autoimmune liver disease, and hypoperfusion. B signs and symptoms 1. Right upper quadrant tenderness 2. Nausea, vomiting 3. Jaundice C diagnosis 1. All patients with clinical or laboratory evidence of moderate to severe acute hepatitis should have a measurement of prothrombin time. If the prothrombin time is prolonged by 4 to 6 SECs or more, ENR 1.5, and there is evidence of altered sensorium, the diagnosis of ALF is established and hospital admission is mandatory. 3. Since ALF may progress rapidly, early transfer to the ICU is recommended once the diagnosis of ALF is made. 4. Seek specific cause of ALF. D. Treatment. 1. Admit patient to ICU. 2. Specific treatment is dependent on etiology of ALF. 3. Consider need for liver transplantation. 2. Acetaminophen hepatotoxicity. A. General information 1. In the United States, acetaminophen, APAP, is the leading cause of acute liver failure. 2. APAP is a dose-related toxin. To cause toxicity, an acute overdose usually totals 150 milligrams kg, about 7.5 grams in adults within 24 HRS. 3. The main toxic metabolite of APAP is N-acetyl-P-benzoquinone imine NAPQ, which is produced by the hepatic 450 system. Glutathione in the liver normally detoxifies NAPQ. An acute overdose of APAP depletes glutathione stores, which results in an accumulation of NAPQ that causes hepatocellular necrosis. 4. Likelihood and severity of hepatotoxicity from an acute APAP ingestion is predicted by the serum APAP level. B signs, symptoms, and labs. Post-ingestion times. 1. Stage I 0 to 24 HRSA, anorexia, nausea, vomiting 2. Stage II, 24 to 72 HRS. Right upper quadrant pain, elevated aspartate aminotransferase, AST, alanine aminotransferase. Possible elevation of bilirubin and prothrombin time, PTT 3. Stage III, 72 to 96 HRS. Vomiting, peaking of AST, ALT, bilirubin, and INR 4. Stage 4, greater than 5 days. Resolution of hepatotoxicity or progression to multiple organ failure. Hepatic disorders 993. C treatment 1. Administer activated charcoal A, ideally give within 1 HR of ingestion. It may be of benefit as long as 3 to 4 HRS after ingestion. B. Adult oral dose, 25 to 100 grams as a single dose. If multiple doses are needed, additional doses may be given as 12.5 grams H. 2. Administer N-acetylcysteine, acetadote. N-acetylcysteine is a precursor for glutathione and decreases APAP toxicity by increasing glutathione hepatic stores. It does not reverse damage to liver cells that have already been injured. B. Ideally begin treatment within 8 HRS of ingestion. It may be of value 48 HRS or more after ingestion. C. Adult oral dose, 140 milligrams kg, followed by 70 milligrams kg every 4 HRS times 17 doses. D. Adult 4 dose, 150 milligrams kg infused over 60 mins, followed by 50 milligrams kg infused over 4 HRS, followed by 100 milligrams kg infused over 16 HRS. D. Chronic EPAP toxicity 1. Chronic excessive use or repeated overdoses of EPAP can lead to chronic EPAP poisoning. Often patients are treating pain with high doses of EPAP from multiple or single source products. Symptoms may be similar to those symptoms listed with acute ingestion or may be absent. 3. Labs A. If AST and ALT are normal and EPAP level is less than 10 g/ml, significant hepatotoxicity is used. B. If AST and ALT are normal and EPAP level is greater than 10 mg/ml, significant hepatotoxicity is possible. C. If initial AST and ALT are initially high, regardless of EPAP levels, significant hepatotoxicity is assumed. 4. Sometimes N-acetylcysteine is used, but its role is unclear in the treatment of chronic EPAP toxicity. 3rd, hepatitis, inflammation of the liver, A. Hepatitis A1. General information A. The primary means of hepatitis A virus have transmission in the United States is via the fecal-oral route. B. Hepatitis A does not become chronic. C. Most persons with acute disease recover with no lasting liver damage. D. Incubation period is 15 to 50 days, average 28 days. 2. Persons at risk A. Travelers to regions with high or intermediate hepatitis B. Sex contacts of infected persons. C. Household members or caregivers of infected persons. D. Men who have sex with men. E. Users of certain illegal drugs. F. Persons with clotting factor disorders. 3. Prevention A. Vaccination with the full 2-dose series of hepatitis A vaccine, Havrix, Vacta, given 6 months apart. B. Immune globulin administered intramuscularly is available for short-term protection, 3 months against hepatitis A both pre-exposure and post-exposure. C. Good hygiene, for example, hand washing. 4. Signs and symptoms A. Some patients are asymptomatic, particularly young children. B. Symptoms occur abruptly and can include fever, fatigue, jaundice, nausea, vomiting, abdominal pain, loss of appetite, and dark urine. C. Symptoms usually last less than 2 months. 5. Serologic tests A. Acute, IgM, anti-HAV. B. Chronic, not applicable. 994 Chapter 49 the 3rd. A6. Treatment A. Post-exposure prophylaxis 1A. Healthy persons 12 months to 40 years. Hepatitis A vaccine 2 people older than 40 years. Instant message. Instant message immune globulin 3 children younger than 12 months immunocompromised. People with chronic liver disease. IM immune globulin B confirmed infection 1. No specific antivirals are available. 2. Supportive treatment is recommended. B1. General information A. Hepatitis B virus, HBV, is transmitted by contact with infectious blood, semen, and other body fluids. B. Among unimmunized persons, chronic infection occurs in 6% to 10% of adults. In chronically infected persons, 15% to 25% of people will develop chronic liver disease, including cirrhosis, liver failure, or liver cancer. C. Most persons with acute disease recover with no lasting liver damage. D. The incubation period is 45 to 160 days, average 120 days. 2. Persons at risk. A. Infants born to infected mothers. B. Sex partners of infected persons. C. Persons with multiple sex partners. D. Injectable drug users. E. Healthcare workers exposed to blood. F. Hemodialysis patients. 3. Prevention. A. Vaccination with hepatitis B vaccine. Recombivax HB. Injurix B. 1. Infants and children. 3 to 4 doses given over a 6 to 18-month period depending on vaccine type and schedule. 2. Adults. 3 doses given over a 6-month period. B. Passive immunization is obtained with hepatitis B. Immune globulin HBig, which provides temporary protection for about 3 to 6 months. 4. Signs and symptoms. A. Fever, fatigue. B. Nausea, vomiting. C. Abdominal pain. D. Jaundice. E. Joint pain. 5. Serologic tests. A. HB-Sag in acute and chronic infection. B. IgM anti-HBC is positive in acute infection. Only 6. Treatment. A. Acute. 1. No medication. Is available. 2. Provide supportive care. B. Chronic. 1. Goal of treatment is amelioration of hepatic dysfunction and seroconversion of HBsAg positive surface antigen to HBsAg negative and production of HBs. And 2. Treatment is indicated for chronic HBV infection with hypertreatment alt level, detectable serum HBV DNA, and moderately active necroinflammation with or without fibrosis on liver biopsy. 3. First-line drugs. A. Pegylated interferon alpha-2A, Pegasus. I. Class interferon SA dose 180 mcg SQ weekly duration 48 weeks. Hepatic disorders 995. B. Entecavir, Baraclude. I. Class reverse transcriptase inhibitor nucleoside A dose 0.5 milligrams daily. Duration for Hepatic antigen is a marker for active replication. Treat for more than 1 year until HB seroconversion and undetectable serum HBV DNA. Continue treatment for more than 6 months after HB seroconversion. IV duration for HB negative. Treat for more than 1 year until HBsAg surface antigen clearance. C. Tenofovir, Vired. I. Class reverse transcriptase inhibitor nucleotide dose 300 milligrams daily. Duration for HB. Treat for more than 1 year until HB seroconversion and undetectable serum HBV DNA. Continue treatment for more than 6 months after HB seroconversion. IV duration for HB negative. Treat for more than 1 year until HBsAg clearance. C. Hepatitis C1. General information. A. Hepatitis C virus, HCV, is transmitted by contact with blood of an infected person. B. Of people newly infected, 75% to 85% develop a chronic infection. B. Of people newly infected, 75% to 85% develop a chronic infection. Of these chronically infected persons, 60% to 70% will develop chronic liver disease such as cirrhosis or liver cancer. C. The incubation period is 14 to 180 days, average 45 days. Persons at risk: A. Current or former injectable drug users. B. Recipients of clotting factor concentrates before 1,987 Celsius. Recipients of blood transfusions before 1992. D. Long-term hemodialysis patients. E. Healthcare workers after needle sticks. F. HIV-infected persons. G. Babies born to infected mothers. 3. Prevention. A. No vaccines are available. B. Don't reuse needles. 4. Signs and symptoms. A. Fever, fatigue. B. Nausea, vomiting. C. Abdominal pain. D. Jaundice. E. Joint pain. 5. Serologic tests. A. Acute. No serologic markers. B. Chronic wound. A. Screening assay for anti-HCV. 2. Verification by a specific assay for HCV RNA 6. Treatment. A. Acute. 1. There is no specific treatment for acute exposure until viremia is established. 2. Typically, a period of at least 12 weeks is observed to see if the HCV will spontaneously clear. If it does not clear, then the patient should be treated. 3. Pegylated interferon monotherapy can cure recent HCV infection in approximately 90% of the patients. B. Chronic wound. All patients with chronic hepatitis C are potential candidates for antiviral therapy with combination pegylated interferon and ribavirin. For patients with chronic HCV genotype 1 who are candidates for therapy, it is recommended that they receive triple therapy with pegylated interferon, ribavirin, and 1 protease inhibitor, telaprevir or boceprevir. 996 Chapter 49 the third. C. 2. The actual duration of treatment is determined in part by viral response. Viral load should be monitored throughout therapy. 3. Medications for HCV genotype 1. A. Pegylated interferon alpha 2A Pegases. I. Class interferon assay dose 180 mcg SQ weekly. The third duration 48 weeks. B. Ribavirin Copagus weight-based dosing. I. Class antiviral dose. If weight is less than or equal to 75 kilograms, then 1,000 milligrams per day divided into 2 doses, or if weight is greater than 75 kilograms, then 1,200 milligrams per day divided into 2 doses. The third duration 48 weeks. COC boceprevir Victrellis. I. Class antiviral protease inhibitor dose 800 milligrams TID. Third duration after 4 weeks of lead-in treatment with pegylated interferon alpha and ribavirin only. Boceprevir is combined with pegylated interferon alpha and ribavirin for 24 to 44 weeks. D. Telaprevir. I. Class antiviral protease inhibitor dose 750 milligrams TID. Duration together with pegylated interferon alpha and ribavirin for 12 weeks, followed by an additional 12 to 36 weeks of pegylated interferon alpha and ribavirin only. 4. Medications for HCV genotypes 2, 3, and 4. A. Pegylated interferon alpha 2A Pegases. I. Class interferon E. Dose 180 mcg SQ weekly. Duration genotype 2 or 3. 24 weeks. IV duration genotype 4. 48 weeks. B. Ribavirin Copagus. I. Class, antiviral, dose genotype 2 or 3, 800 milligrams per day, divided into 2 doses, the third duration genotype 2 or 3, 24 weeks, IV, dose genotype 4. Weight is less than or equal to 75 kilograms, then 1,000 milligrams per day, divided into 2 doses, or if weight is greater than 75 kilograms, then 1,200 milligrams per day, divided into 2 doses. D. Duration, genotype 4, 48 weeks. D. Hepatitis D1. General information. A. Hepatitis D virus, HDV, is transmitted through percutaneous or mucosal contact with infectious blood. HDV is an incomplete virus that requires the helper function of HBV to replicate and only occurs in people infected with HBV. C. HDV is uncommon in the United States. 2. Persons at risk. A. Persons infected with HBV. B. Injectable drug users. 3. Prevention. A. There is no vaccine for HDV. B. Give hepatitis B vaccine to prevent infection with HBV. 4. Signs and symptoms. A. Fever, fatigue. B. Nausea, vomiting. C. Abdominal pain. Hepatic disorders 997. D. Jaundice. E. Joint pain. 5. Serologic tests. A. Acute B1A IgM anti-HDV. 2. HDAG-B chronic. HDAG-6. Treatment. Pegylated interferon alpha E. Hepatitis E1. General information. A. Hepatitis E virus, HEV, is spread by the fecal-oral route. B. HEV usually results in a self-limited acute illness. C. HEV is uncommon in the United States. 2. Persons at risk are those who travel to developing countries. 3. Prevention. A. Good sanitation. B. Clean drinking water. 4. Signs and symptoms. A. Fever, fatigue. B. Nausea, vomiting. C. Abdominal pain. D. Jaundice. E. Joint pain. 5. Treatment. A. Hepatitis E usually resolves on its own. B. Treatment is supportive, for example, rest, fluids. 4th. Alcohol-induced liver disease. A. General information. 1. The cause of alcoholic liver disease, ALD, is chronic, heavy alcohol ingestion. A. About 40 to 80 grams per day in men for 10 to 12 years. B. About 20 to 40 grams per day in women for 10 to 12 years. 2. Prevalence in the United States is estimated at greater than 2 million people. B. Stages of liver damage. 1. Fatty liver. A. It is represented by a fatty infiltration in the liver. B. Clinical findings include hepatomegaly and mild liver enzyme abnormalities. C. The condition is potentially reversible if alcohol is stopped and nutrition maintained. Alcoholic hepatitis. A. It is characterized by hepatic inflammation with necrosis. B. Clinical features include fever, abdominal pain, anorexia, nausea, and weight loss. 3. Cirrhosis. A. It is marked by severe hepatic fibrosis. B. ALD is the most common cause of cirrhosis. C. Signs and symptoms. 1. Fatigue. 2. Anorexia, weight loss. 3. Nausea, vomiting. 4. Jaundice. 5. Right upper abdominal pain. D. Liver-related labs. 1. In ALD patients, the AST is almost always elevated. 2. The classic ratio AST-ALT greater than 2 is seen in 70% of the cases. ALT and AST may be in the normal range in patients with advanced cirrhosis due to the lack of viable hepatocytes left to produce transaminases. 998 Chapter 49 E treatment. 1. No approved pharmacotherapy. 2. Alcohol abstinence. 3. Optimal nutrition. 4. Consideration for liver transplantation in patients with end-stage ALD. 5th. Cirrhosis. A. General information. 1. Cirrhosis describes a diseased liver characterized by fibrosis, usually due to many years of continuous injury. 2. The most common causes of cirrhosis are A. Long-standing alcohol abuse, B. Chronic hepatitis B or CC, non-alcoholic steatohepatitis. 3. Cirrhosis has no cure. B. Classification 1. Compensated cirrhosis. A. Cirrhosis present. B. Preservation of hepatic synthetic function. C. No evidence of complications related to portal hypertension, hepatic encephalopathy, and/or jaw. Decompensated cirrhosis. A. Cirrhosis present. B. Reduced hepatic synthetic function. C. Portal hypertension, including ascites, gastroesophageal varices, and variceal bleeding. D. Hepatic encephalopathy. E. Jaundice. C. Signs and fatigue. 2. Jaundice. 3. Varices. 4. Ascites. 5. Edema. 6. Hepatic encephalopathy. D. Treatment. 1. Treat underlying causative condition, for example, hepatitis B, hepatitis C. 2. Avoid substances that injure the liver, for example, alcohol, high dose of PEP. 3. Complications. A. Ascites. The most common complication, O&A, dietary sodium restriction, less than 2 grams per day. 2. Diuretics. A combination of spironolactone, aldactone, and furosemide. Lasix is the usual diuretic regimen. B. Starting doses are usually 100 mg spironolactone and 40 mg furosemide. C. Doses can be increased every 3 to 5 days with typical maximal doses of 400 mg per day of spironolactone and 160 mg per day of furosemide. Avoid non-steroidal anti-inflammatory drugs, NSAIDs. B. Refractory ascites. O&A. This condition is defined as fluid overload that is unresponsive to a sodium-restricted diet and high-dose diuretic treatment, or recurs rapidly after therapeutic paracentesis. 2. Options. A. Large volume paracentesis, LVP, and albumin replacement. B. Transjugular intrahepatic portosystemic shunt. Tips. See consideration for liver transplantation. Hepatic disorders. 999. C. Esophageal varices. 1A. Acute bleeding in a cirrhotic patient. A. Admit patient to intensive care unit, ICU, for resuscitation and management. B. Maintain hemoglobin at 8 grams DL. I. Shown to increase survival rate. Norfloxacin, Noroxin, 400 mg bid orally, or ceftriaxone, Rocephin, 1 gram daily. Ivor. D. Initiate octreotide sandostatin at 50 mcg. Ivor bolus followed by 50 mg HR continuous infusion for 3 to 5 days for vasoconstriction. E. Use sclerotherapy or endoscopic variceal ligation, EVAL, to control hemorrhage. Balloon tamponade can be used to temporarily control bleeding by applying pressure to the bleeding sites. G. If the above measures fail, then a shunt, for example, TIPS, is indicated. 2. Ongoing prevention. A. Initiate a non-selective blocker, for example, Nadolol, Corguard, propranolol, Inderal. B. Conduct an EVL, CO. If the aforementioned therapy fails, a shunt, for example, TIPS, should be considered. D. Hepatic encephalopathy. 1. Encompasses a spectrum of neuropsychiatric abnormalities as a result of liver dysfunction. A. Cognitive deficits. B. D. Extrapyramidal alterations. E. C. Sleep disturbances. 2. Ammonia has been implicated as a neurotoxin in the pathogenesis of this condition. A. Ammonia is a byproduct of protein metabolism and is normally metabolized by the liver to urea, blood urea nitrogen of Bonneau, which is renally eliminated. B. Cirrhosis impairs hepatic blood flow and metabolism, which can result in increased levels of ammonia in the central nervous system. CN 3. Treatment options: A. Correct precipitating factors, for example, excessive protein intake, infection. B. Reduce nitrogenous load. I. Reduce protein intake. D. Administer lactulose annulose 20 to 30 grams, 30 to 45 milliliters, 3 to 4 times a day. Lactulose results in acidification of the colon, which converts ammonia into a less readily absorbed ammonium ion. Study questions. Directions. Each of the questions, statements, or incomplete statements in this section can be correctly answered or completed by one of the suggested answers or phrases. Choose the best answer. 1. What is the toxic metabolite that builds up with an acute acetaminophen overdose? A. Glutathione. B. NAPQ, HBV, DLD, and acetylcysteine. What are the 3 first-line drugs for the treatment of chronic hepatitis B? A. Lamivudine, telbivudine, entecavir. B. Pegylated interferon alpha, lamivudine, acyclovir, telbivudine. Tenofovir. D. Pegylated interferon alpha, entecavir, tenofovir. E. Entecavir, acyclovir, telbivudine. 1000 Chapter 49. 1. The answer is B. C. 3. The main toxic metabolite of APAP metabolism is NAPG. Normally, glutathione in the liver detoxifies NAPG, but an acute overdose of APAP depletes glutathione stores, which results in accumulation of NAPG, which causes hepatic necrosis. The answer is D. See the third B6B 3. The American Association for the Study of Liver Diseases, AASLD, has stated that the first-line drugs for the treatment of chronic hepatitis B are pegylated interferon alpha, entecavir, and tenofovir. In choosing which antiviral agent to use as the first-line therapy, consideration should be given to the safety and efficacy of the treatment, risks of drug resistance, and costs. The answer is A. CVD3D3. B. Lactulose annulose 20 to 30 grams, 30 to 45 milliliters, administered 3 to 4 times a day, is given to patients with hepatic encephalopathy. Lactulose results in acidification of the colon, which converts ammonia into a less readily absorbed ammonium ion, therefore decreasing the nitrogenous load. 4. The answer is E. C2. And acetylcysteine is a precursor for glutathione and decreases APAP toxicity by increasing glutathione hepatic stores. It does not reverse damage to liver cells that have already been injured. Ideally, begin treatment within 8 HRS of ingestion. It may be of value 48 HRS or more after ingestion. 5. The answer is B. See the third A3A, the third. It can be prevented with the full 2-dose series of hepatitis A vaccine given 6 months apart in adults. Hepatitis B can be prevented with a 3-dose series of hepatitis B vaccine given over a period of 6 months in adults. 6. The answer is D. CVB3. Alcoholic liver disease is the most common cause of cirrhosis in the United States. Alcohol is metabolized in the liver, and oxidative stress promotes hepatocyte necrosis, and severe hepatic fibrosis develops. 7. The answer is E. CVD3C. 1. Pharmacologic therapy, such as octreotide, should be initiated as soon as variceal hemorrhage is suspected, and continued for 3 to 5 days. The vasoconstrictive action of octreotide helps to control bleeding. Answers and explanations. 3. What medication is administered to patients with hepatic encephalopathy to decrease nitrogenous load? A. Lactulose. B. furosemide, 2, C, spironolactone, D, propranolol, E, norfloxacin. 4. What medication is administered to patients to decrease APAP toxicity? A. Naloxone, B. Interferon alpha, tenofovir, D. Neomycin, E. N-acetylcysteine. 5. Which types of viral hepatitis have vaccines available? B. Hepatitis A and B. Hepatitis A, Hepatitis B and C. D. Hepatitis A and C. Hepatitis A and C. 6. What is the most common cause of cirrhosis? A. APAP toxicity, B. Hepatitis A, hepatitis E, D. Alcoholic liver disease, E. Renal dysfunction. 7. What medication may be used to treat bleeding of esophageal varices by causing vasoconstriction? A. Propranolol, B. Spironolactone, C. Ribavirin, D. Diphenhydramine, E. Octreotide. 1001. Cancer chemotherapy. 50. Brooke Bernhardt, I Principles of Oncology. The term cancer refers to a heterogeneous group of diseases caused by an impairment of the normal functioning of genes, which leads to genetic damage. A. Characteristics of cancer cells. Cancer cells are also referred to as tumors or neoplasms. Tumors are thought to arise from a single abnormal cell, which continues to divide indefinitely. Uncontrolled growth, the ability to invade local tissues, and the ability to spread or metastasize are unique characteristics of cancer cells. 1. Carcinogenesis. The mechanism of how many cancers occur is thought to be a multi-stage, multifactorial process that involves both genetic and environmental factors. A. Initiation. The first step involves the exposure of normal cells to a carcinogen, producing genetic damage to a cell. B. Promotion. The environment becomes altered to allow preferential growth of mutated cells over normal cells. The mutated cells become cancerous. C. Progression. Increased proliferation of cancer cells allows for invasion into local tissue and metastasis. 2. Types of cancer. Tumors can be benign or malignant. Benign tumors are generally slow-growing, resemble normal cells, are localized, and are not harmful. Malignant tumors often proliferate more rapidly, have an atypical appearance, invade and destroy surrounding tissues, and are harmful if left untreated. Malignant cancers are further categorized by the location from where the tumor cells arise. A. Solid tumors. Carcinomas are tumors of epithelial cells. These include specific tissue cancers, for example, lung, colon, breast. Sarcomas include tumors of connective tissue such as bone, for example, osteosarcoma, or muscle, for example, leiomyosarcoma. B. Hematological malignancies. Lymphomas are tumors of the lymphatic system and include Hodgkin and non-Hodgkin lymphomas. Leukemias are tumors of blood-forming elements and are classified as acute or chronic and myeloid or lymphoid. B. Incidence. Cancer is the second leading cause of death in the United States. The most common cancers are breast, prostate, and colorectal. The leading cause of cancer death is lung cancer. C. Cause. Many factors have been implicated in the origin of cancer. Some of these factors are as follows. 1. Viruses including Epstein-Barr virus, EBV, hepatitis B virus, HBV, and human papillomavirus, HPV. 2. Environmental and occupational exposures, such as ionizing and ultraviolet radiation and exposure to chemicals, including vinyl chloride, benzene, and asbestos. 3. Lifestyle factors, such as high-fat, low-fiber diets and tobacco and ethanol use. 4. Medications, including alkylating agents and immunosuppressants. 5. Genetic factors, including inherited mutations, cancer-causing genes, oncogenes, and defective tumor suppressor genes. Detection and diagnosis are critical for the appropriate treatment of cancer. Earlier detection may improve response to treatment. 1. Warning signs of cancer have been outlined by the American Cancer Society. General signs and symptoms of cancer may include unexplained weight loss, fever, fatigue, pain, and skin changes. Signs and symptoms of specific types of cancer can include changes in bowel habits or bladder. 1002 Chapter 50 ID function. A sore that does not heal, white patches or spots in the mouth or on the tongue, unusual bleeding or discharge, thickening or lump in the breast or other body part, indigestion or difficulty swallowing, a recent change in a wart or mole, other skin changes, or a nagging cough or hoarseness. Guidelines for screening asymptomatic people for the presence of cancer have been established by the American Cancer Society, the National Cancer Institute, and the U.S. Preventive Health Services Task Force, among others. Because many cancers do not produce signs or symptoms until they have become large, the goal of screening is to detect cancers early, when the disease may be more likely to be curable, thus potentially reducing cancer-related mortality. The different sets of guidelines vary slightly in their recommendations for age and frequency of screening procedures. 3. Tumor markers are biochemical indicators of the presence of neoplastic proliferation detected in serum, plasma, or other body fluids. These tumor markers may be used initially as screening tests, to reveal further information after abnormal test results, or to monitor the efficacy of therapy. Elevated levels of these markers are not definitive for the presence of cancer because levels can be elevated in other benign and malignant conditions, and false positive results do occur. Examples of some commonly used markers include the following: A. Carcinoembryonic antigen, CA, for colorectal cancer. B. Fetaprotein, AFP, for hepatocellular carcinoma or hepatoblastoma. C. Prostate-specific antigen, PSA, for prostate cancer. 4. Tumor biopsy. The definitive test for the presence of cancerous cells is a biopsy and pathological examination of the biopsy specimen. Several types of procedures are used in the pathological analysis of tumors, including evaluating the morphological features of the tissue and cells via pathologic evaluation, looking for cell surface markers via flow cytometry, and cytogenetic evaluation for specific chromosomal abnormalities via fluorescence in situ hybridization. 5. Imaging studies, such as radiograph CT scans, MRI, and positron emission tomography, PET, may be used to aid in the diagnosis or location of a tumor and to monitor response to treatment. 6. Other laboratory tests commonly used for cancer diagnosis include complete blood counts, CBCS, and blood chemistries. A CBC measures the levels of the 3 basic blood cells: white cells, red cells, and platelets. The CBC will often include an absolute neutrophil count, ANC, which measures the absolute number of neutrophils in a person's white blood count. The ANC is calculated by multiplying the white blood count, WBC, total neutrophils, segmented neutrophils percent, segmented bands percent, ANC. Segmented neutrophils are often listed as polys, and segmented bands are immature polys. Staging is the categorizing of patients according to the extent of their disease. The stage of the disease is used to determine prognosis and treatment. In adult patients with cancer, 2 different staging systems are widely employed for the staging of neoplasms. 1. TNM classification. AT indicates tumor size and is classified from 0 to 4, with 0 indicating the absence of tumor. BN indicates the presence and extent of regional lymph node spread and is classified from 0 to 3, with 0 indicating no regional lymph node involvement and 3 indicating extensive involvement. CM indicates the presence of distant metastases and is classified as 0 for absence or 1 for presence of distant metastases. D, for example, to unknown meter 0 indicates a moderate-sized tumor with limited nodal disease and no distant metastases. AJCC staging, developed by the American Joint Committee on Cancer, classifies cancers as stages 0 to IV, and assigned TNM translates into a stage. A high number indicates larger tumors with extensive nodal involvement and/or metastasis. Generally, high numbers also indicate a worse prognosis. There are specific staging criteria for each tumor type. F survival depends on the tumor type, the extent of disease, and the therapy received. Although some patients are free of all detectable disease, not all patients are cured. The terms complete response and remission are used to indicate that the patient has no evidence of disease after treatment. This is not a synonym for cure, as several patients who have achieved complete remission may relapse. Other markers used to describe disease response or survival include partial response, APR, very good partial response, VGPR, stable disease, SD, progressive disease, PD, time to progression, TTP, and progression-free survival, GFS. Cancer chemotherapy 1003. 2. Cell life cycle. Knowledge of the cell life cycle and cell cycle kinetics is essential to the understanding of the activity of chemotherapy agents in the treatment of cancer. Figure 15-1. A phases of the cell cycle. 1. M phase, or mitosis, is the phase in which the cell divides into 2 daughter cells. 2. Gone phase, or postmitotic gap, is when RNA and the proteins required for the specialized functions of the cell are synthesized in preparation for DNA synthesis. S phase is the phase in which DNA synthesis and replication occurs. 4. GT2 phase, or the premitotic or postsynthetic gap, is the phase in which RNA and the enzymes topoisomerase I and a second are produced to prepare for duplication of the cell. 5. G0 phase, or resting phase, is the phase in which the cell is not committed to division. Cells in this phase are generally not sensitive to chemotherapy. Some of these cells may re-enter the actively dividing cell cycle. In a process called recruitment, some chemotherapy regimens are designed to enhance this re-entry by killing a large number of actively dividing cells. B. Cell growth kinetics. Several terms describe cell growth kinetics. 1. Cell growth fraction is the proportion of cells in the tumor dividing or preparing to divide. As the tumor enlarges, the cell growth fraction decreases because a larger proportion of cells may not be able to obtain adequate nutrients and blood supply for replication. Cell cycle time is the average time for a cell that has just completed mitosis to grow and again divide and again pass through mitosis. Cell cycle time is specific for each individual tumor. Tumor doubling time is the time for the tumor to double in size. As the tumor gets larger, its doubling time gets longer because it contains a smaller proportion of actively dividing cells owing to restrictions of space, nutrient availability, and blood supply. 4. The Gompertzian growth curve illustrates these cell growth concepts. Figure 15-2. C. Tumor cell burden is the number of tumor cells in the body. 1. Because a large number of cells is required to produce symptoms and be clinically detectable, approximately 109 cells, the tumor may be in the plateau phase of the growth curve by the time it is discovered. The cell kill hypothesis states that a certain percentage of tumor cells will be killed with each course of cancer chemotherapy. As tumor cells are killed, cells in G0 may be recruited into GON, resulting in tumor regrowth. Thus, repeated cycles of chemotherapy are required to achieve a complete response or remission. Figure 50-3. The percentage of cells killed depends on the chemotherapy dose. In theory, the tumor burden would never reach absolute zero because only a percentage of cells are killed with each cycle. Less than 104 cells may depend on elimination by the host's immune system. Figure 50-1. The cell cycle. The cell growth cycle, emphasizing the relationship between proliferating cell populations. Reprinted with permission from Lenhard Jr., Austin R.T., Gansler T. edi., The American Cancer Society's Clinical Oncology. Atlanta, Georgia, American Cancer Society, 2001. MSGTU, Gone cell death. G0. Cells are reversibly out of cycle, for example, as a result of nutrient deprivation, may serve as a reserve for repopulation of a tissue. Cells are irreversibly out of cycle, for example, as the result of maturation, differentiation. 1004 Chapter 52. Chemotherapeutic agents may be classified according to their reliance on cell cycle kinetics for their cytotoxic effect. Combinations of chemotherapy agents that are active in different phases of the cell cycle may result in a greater cell kill. A cell cycle classification of some commonly used chemotherapeutic agents is given into Section D. 1. Phase-specific agents are most active against cells that are in a specific phase of the cell cycle. These agents are most effective against tumors with a high growth fraction. Theoretically, administering these agents as continuous intravenous infusions or by multiple repeated doses may increase the likelihood of hitting the majority of cells in the specific phase at any one time. Therefore, these agents are also considered schedule-dependent agents. Examples are as follows: AM phase, mitotic inhibitors, for example, vinca alkaloids, taxanes B, GON phase, asparaginase, prednisone C, S phase, antimetabolites D, GTU phase, bleomycin, etoposide. Figure 50-2. The Gompertzian growth curve. During the early stages of its development, a tumor grows exponentially. But as a tumor enlarges, its growth slows. By the time a tumor becomes large enough to cause symptoms and be clinically detectable, the majority of its growth has already occurred and is no longer exponential. Reprinted with permission from Lenhard Jr., Austin R.T., Gansler T. edi., The American Cancer Society's Clinical Oncology. Atlanta, Georgia, American Cancer Society, 2001. 1012, 1011, 1010, 109, 108, 107, 106 cell. Number 105, 104, 103, 102, 101, 100, 12, 111, 118, 109, 108, 107, 107, 105, 104, 103, 102, 101, 100. Time. Limit of clinical detection. Figure 50-3. Chemotherapy and tumor cell survival. Relationship between tumor cell survival and chemotherapy administration. The exponential relationship between chemotherapy drug dose and tumor cell survival dictates that a constant proportion, not number, of tumor cells is killed with each cycle of treatment. In this example, each cycle of drug administration results in 99.9%, 3 log cell kill, and 1 log of cell regrowth occurs between cycles. The broken line indicates what would occur if the last cycle of therapy were omitted. Despite complete clinical remission of disease, the tumor would ultimately recur. Reprinted with permission from Lenhard Reed Jr., Austin R.T., Gansler T., eds. The American Cancer Society's Clinical Oncology. Atlanta, Georgia. American Cancer Society, 2001, 1012, 1011, 1010, 109, 107, 106, 105, 104, 103, 102, 101, 100. Cell number, time, tumor regrowth following premature cessation of therapy, disease and clinical remission. Clinically overt disease, 3 log cell kill, 1 log cell regrowth. Cycles of chemotherapy, 1, 2, 3, 4, 5. Cancer chemotherapy, 1005, 2. Phase non-specific agents are effective while cells are in the active cycle, but do not require that the cell be in a particular phase. These agents generally show more activity against slow-growing tumors. They may be administered as single bolus doses because their activity is independent of the cell cycle. These drugs are also considered dose-dependent agents. Examples are alkylating agents and anti-tumor antibiotics. 3. Cell cycle. Non-specific agents are effective in all phases, including G0. Examples are carmustine and lomustine. Radiation therapy is also considered cell cycle non-specific. 3rd, chemotherapy. Objectives of chemotherapy. 1. For cancers like leukemias and lymphomas, several phases of chemotherapy are necessary. A cure may be sought with aggressive therapy for a prolonged period to eradicate all disease. For leukemias, this curative approach may consist of the following components. A. Remission induction, therapy given with the intent of maximizing cell kill. B. Consolidation, also known as intensification or post-remission therapy. Therapy to eradicate any clinically undetectable disease and to lower the tumor cell burden below 103, at which level host immunological defenses may keep the cells in control. C. Maintenance. Therapy given in lower doses with the aim of maintaining or prolonging a remission. 2. For solid tumors, one or more approaches to chemotherapy may be used when seeking a cure based on the known utility of chemotherapy in line with other modalities, such as surgery or radiation. Adjuvant chemotherapy is given after more definitive therapy, such as surgery, to eliminate any remaining disease or undetected micrometastasis. B. Neoadjuvant chemotherapy is given to decrease the tumor burden before definitive therapy, such as surgery or radiation. 4. Palliative therapy is usually given when complete eradication of the tumor is considered unlikely or the patient refuses aggressive therapy. Palliative chemotherapy may be given to decrease the tumor size, control growth, and reduce symptoms. 5. Salvage chemotherapy is given as an attempt to get a patient to remission after previous therapies have failed. B. Chemotherapy dosing may be based on body weight, body surface area, BSA, or area under the concentration versus time curve, AEC. BSA is most frequently used because it provides an accurate comparison of activity and toxicity across species, making it easier to translate preclinical dosing into clinical trials and practice in humans. In addition, BSA correlates with cardiac output, which determines renal and hepatic blood flow and thus affects drug elimination. In very young or very small patients, for example, infants less than a year of age or less than 10 to 12 kilograms of body weight, the BSA is not a good measure for calculating the dose, as it can overestimate the patient's size and lead to overdosing of chemotherapeutic agents, resulting in excessive toxicities. In this patient population, dosing chemotherapy based on body weight in kilograms is often a more frequently employed technique. Dosing adjustments may be required for kidney or liver dysfunction to prevent toxicity. For some agents, dose adjustments are also made based on hematologic or non-hematologic toxicities. Very little is known about dosing chemotherapy in the obese population. Combination chemotherapy is usually more effective than single-agent therapy. 1. When combining chemotherapy agents, factors to consider include A. Anti-tumor activity. B. Different mechanisms of action. C. Minimally overlapping toxicities. 2. The reasons for administering combination chemotherapy include A. Overcoming or preventing resistance. B. Cytotoxicity to resting and dividing cells. C. Biochemical enhancement of effect. D. Rescue of normal cells. 3. Dosing and scheduling of combination regimens are important because they are designed to allow recovery of normal cells. These regimens generally are given as short courses of therapy in cycles. 1006 Chapter 50 the third. D4. Acronyms often are used to designate chemotherapy regimens. For example, CMF refers to a combination of cyclophosphamide, methotrexate, and fluorouracil used in the treatment of breast cancer. E. Administration. 1. Routes of administration vary depending on the agent and the disease state. Although intravenous IV administration is most commonly employed, oral administration of chemotherapy is becoming increasingly more common. Other administration techniques include oral, subcutaneous, intrathecal, intraarterial, intraperitoneal, intravesical, continuous IV infusion, bolus IV infusion, and hepatic artery infusion. Drugs that may be given intrathecally include methotrexate, cytarabine, and hydrocortisone. Drugs should not be administered by the intrathecal route without specific information supporting intrathecal administration. Inadvertent administration of vinca alkaloids, for example, vincristine, by the intrathecal route results in ascending paralysis and death. The U.S. Food and Drug Administration, FDA, requires that specific wording alerting the provider to this error must be included on the packaging of each dose of vincristine. They also recommend that safety measures are employed in the preparation and delivery of vinca alkaloids. 4. Products with different formulations, including liposomal or pegylated agents, for example, liposomal doxorubicin, pegfilgrastim, are being used to decrease frequency of administration and/or reduce toxicities. F. Response to chemotherapy is defined in several ways and does not always correlate with patient survival. 1. Complete response, CRR, indicates disappearance of all clinical, gross, and microscopic disease. PR indicates a greater than 50% reduction in tumor size, lasting a reasonable period. Some evidence of disease remains after therapy. 3. Response rate, RR, is defined as CR/PR. 4. SD indicates tumor that neither grows nor shrinks significantly, less than 25% change in size. 5. PD, or no response after therapy, is defined by a greater than 25% increase in tumor size or the appearance of new lesions. G factors affecting response to chemotherapy. 1. Tumor cell heterogeneity. Large tumors have completed multiple cell divisions, resulting in several mutations and genetically diverse cells. Drug resistance. The Goldie-Coldman hypothesis states that genetic changes are associated with drug resistance, and the probability of resistance increases as tumor size increases. The hypothesis assumes that, at the time of diagnosis, most tumors possess resistant clones. A well-studied mechanism of resistance involves the multi-drug resistance MDR gene, which codes for membrane-bound P-glycoprotein. P-glycoprotein serves as a channel through which cellular toxins, that is, chemotherapeutic agents, may be excreted from the cell. 3. Dose intensity is defined as a specific dose delivered over a specific period. Occasionally, the full dose cannot be given or a cycle is delayed owing to complications or toxicities. Suboptimal doses have resulted in reduced response rates and survival. Dose density involves shortening the usual interval between doses to maximize the drug effects on the tumor growth kinetics. 4. Patient-specific factors such as poor functional status, impaired organ function, or concomitant diseases may compromise how a chemotherapy regimen is given and affect how the patient responds to treatment. 4th classification of chemotherapeutic agents. A. Examples of the following agents and their toxicities are listed in Table 50-1. B. Alkylating agents were the first group of antineoplastic agents. The prototype of this class is mechlorethamine, or nitrogen mustard, which was researched as a chemical warfare agent. Alkylating agents cause cross-linking and abnormal base pairing of DNA strands, which inhibit replication of the DNA. This mechanism is known as alkylation. These are phase nonspecific agents. C. Most of the antitumor antibiotics are obtained from organisms of the Streptomyces genus. These agents may act by either alkylation, mitomycin, or intercalation. Intercalation is the process by which the drug slides between DNA base pairs and inhibits DNA synthesis. These are phase nonspecific agents. D. Antimetabolites are structural analogs of naturally occurring substrates for biochemical reactions. They inhibit DNA synthesis by acting as false substitutions in the production of nucleic Cancer chemotherapy 1007, Table 50-1 Cancer chemotherapy